Welcome to the March CE Appetizer program titled Nice Drugs If You Can Get Them, an update on outpatient COVID-19 therapy. This program is accredited for pharmacists only. However, technicians can receive up to 5 hours of pharmacist accredited CE for PTCB recertification. My name is Trish Wagner, and I am the Vice President of Professional Services for the Illinois Council of Health System Pharmacists. So now on to introducing our speakers for today. We have two speakers, Beth, Cady, and Justin Moore. Dr. Cady is Clinical Assistant Professor at SIUE School of Pharmacy and also Clinical Pharmacy Specialist in Infectious Diseases at HSHS St. John's Hospital in Springfield. She received her Doctor of Pharmacy degree from Drake University and then went on to complete a PGY1 and PGY2 in infectious diseases at the University of Kentucky Healthcare. Dr. Cady is also a board certified pharmacotherapy specialist. Dr. Moore is an infectious diseases and antimicrobial stewardship clinical pharmacist at Northwestern Memorial Hospital. He received his Doctor of Pharmacy degree from the University of Georgia. He also went on to complete a PGY1 and a PGY2 in infectious diseases at Northwestern Medicine. Dr. Moore is a board certified pharmacotherapy specialist and also board certified ID pharmacist. Both of our speakers serve on the ICHP Division of Educational Affairs, and Dr. Moore is also chair of the New Practitioners Network. So Dr. Cady, want to take it away?
Yes, thank you, Trish, very much. So for those of you who are maybe Broadway junkies like myself, there is a little bit of a spin on this title. It's kind of an unfortunate spin. There's a Broadway show called Nice Work If You Can Get It, starring Matthew Broderick. And we're going with the spin of, hey, a lot of these new COVID medications are a little bit hard to get our hands on. So they're nice drugs if you can get them. So with that being said, Justin and I don't have anything to disclose here. And if you look at our objectives, we're basically going to be reviewing 3 medications today. We could probably review about 15, but we're trying to keep it narrow, and we're just going to focus on 3 today and figure out what their place is in therapy. So before we jump into the meat of our presentation, we have our first poll. And you might have been thinking, if you look at the title of our slide, you're thinking this is outpatient therapy. A lot of you are probably inpatient pharmacists. Does this affect you? So how many of you out there on the call, how many of your respective institutions have a protocol related to these outpatient therapies? And you can be honest and say, there's a protocol for that? Why would we be involved? So if you want to take a second to pull everywhere and let us know. Well, at least there's one audience member that says, yes, we have a protocol.
Yep, and again, if you want to text ICHP to 22333 and then put in your response, I'll give it a few more seconds.
Yeah, my thought here is depending on the size of your institution and whether or not you've got maybe outpatient clinics that are associated with your institutions, you might play a role. You as an inpatient pharmacist still might be playing a role in how to determine which of these therapies are going to be good. Or if you're a general pharmacist, you're probably getting lots and lots of questions from friends and family members saying, what are these drugs that I can take? So that's another purpose of this talk today. Yeah, not all that uncommon for those of us in the audience to say, I don't really know if we have a protocol yet. So maybe after this, you can talk to some of your coworkers, maybe your stewardship pharmacists, and see, do we have a protocol? Does this align with what I just learned in this presentation? And you might be able to have some updates from today. So moving on, before we discuss the drugs, we at least have to address the spectrum of disease with COVID. We're not going to spend time telling you, hey, there's this novel virus out there, because we're all pretty aware. You're also probably aware that the spectrum of disease can range anywhere from, if we're looking at this graph on the left-hand side, can range anywhere from asymptomatic all the way to critical illness, unfortunately, even death. So when we're talking about the drugs here, if you think about the pathogenesis of the disease, you can see some of our arrows going along this slide. During the viral replication phase, that usually occurs in the asymptomatic, mild, moderate, maybe a little bit into the severe illness stage. So thinking about these, spoiler alert, antivirals that we might be using, especially in the outpatient mild illness setting, we're going to want to target patients who are in that very mild to moderate illness stage. There is also one drug that we're going to talk about that is an antibody. So again, kind of thinking about when to use antivirals and antibody therapies compared to those anti-inflammatory therapies. We're really focusing on the mild or moderate illness. And as we've alluded to it in the title, we're going to be looking at outpatient therapies. So we're focusing on mild and moderate illness. So the next question, which kind of relates back to our title, is, hey, this would be great if we've got a ton of drugs to use for our patients in the outpatient setting who have a high risk of progression to severe disease. But as we know, some of these drugs are not necessarily the easiest to get. So the CDC has created a tiering system with patients who are at different levels of risk. I'm not necessarily going to read through all of these levels of risk, but it can range anywhere from patients who are immunocompromised, patients who are unvaccinated. How do we define unvaccinated? Is it going to be without that booster? Is it going to be just one shot, 2 shots? What are their ages? So the CDC has prioritized or tiered patients based on their risk of progression. And from this tiering system, we can decide, okay, which patients should probably get these antiviral therapies or these antibody therapies. So we know when to use it in that mild disease in the outpatient setting. We know the medications are hard to come by. Now let's actually jump into the drug therapy. So from this, I'm thinking lions and tigers and bears, oh my. Within the last few months, there have been so many medications that have been thrown at us that it's almost hard to keep them all straight. So like we said, we're going to focus on just 3 of them today. And with that, we're going to start with the monoclonal antibody, which is sotrovimab. Now, as I talk to you about sotrovimab, I want to tell you that this slide is already outdated. Justin and I were kind of joking with each other, saying the minute we submit these slides, there's no doubt going to be a new piece of data that comes out. So the COMET ICE trial, which thank goodness we've got some really cool names for these trials because they're going to be easier to remember the data. But with the COMET ICE trial, they released a preliminary analysis a while ago. I felt very confident. I put this slide set together, and I kid you not, Justin and I were communicating last week, and he says, did you see that they just published the full data set from COMET ICE? And I said, yep. Doesn't that figure? So this is already an outdated slide. However, the results are pretty similar. So if we're looking at what got sotrovimab, the EUA, if you look at the inclusion criteria, it's going to be fairly similar to what we're seeing with a lot of patients with all of these drug therapies across the board. They have to be at least 18. They have to have one risk factor. Again, we're trying to prevent the progression of disease. Who is disease going to progress mostly in? Patients with these risk factors. FYI, these patients were all unvaccinated and they could not be hospitalized. So you could not be hospitalized with COVID-19. So the outcome, fairly typical outcome from what we're looking at with these kinds of studies. We're looking at hospitalization or death within the next 29 days. Remember, this is the preliminary data. The full data that just got published, the numbers are kind of the same. If you just double the size, the sotrovimab and the placebo group, they had about 500 in each group, but the percentages were fairly similar. So that primary outcome of death or hospitalization occurred in 1% of patients in the sotrovimab group and 7% of the time in the placebo group. And I did differentiate how many deaths were in each versus hospitalization. So deaths, fortunately, were fairly low for both groups. And I just included a few different parameters of patients that were included just to see what kind of representation we could get from the populations and what kinds of risk factors they had. So overall, from the results, the percentages look good. The relative risk reduction on an adjusted measurement was 79%, and this was statistically significant. So that led to the EUA and some of our take-home points. There have been a few other pieces of information with sotrovimab, but with all that other information, I'm basically saying the take-home point with the current EUA, we've got one dose, gotta be IV, you can give it over 15 minutes. What's really great about sotrovimab, no dosage adjustments, no drug monitoring parameters. The side effects were fairly minimal. There's no interactions, and you do want to make sure you give it within 7 days of symptom onset. That's the COMET-I study that looked at sotrovimab IV versus placebo. The COMET-Tail study, just slightly different. The results are not fully out yet, but as you can imagine, getting outpatient therapy with an IV infusion is probably not going to be the most convenient thing. So the COMET-Tail study said, all right, let's take sotrovimab. We know that it's already good. Let's compare sotrovimab IV to sotrovimab IM. Looking at the inclusion and exclusion criteria, it's going to be fairly similar to COMET-ICE. And the outcome, same thing, progression of disease within 29 days. So the full results are not really published yet. And the reason that I wanted to include this study for this presentation is because there is talk of, can we get any of these monoclonal antibodies to be an intramuscular injection? Wouldn't that be nice? We don't have to set up an IV infusion. Again, the data is not there yet, but it looks promising. And I included the IV infusion just to confirm that there were 0 deaths in this study and the progression of disease was, 1.3%. So again, just proving that sotrovimab, pretty decent. And again, showing you a little bit of our patient population. Take home points, I have the same things listed here. COMET-Tail, it sounds like we might get an IM version of this, but I'm not willing to say it yet because the data's not out yet, but stay tuned. So from a standpoint of where we're using sotrovimab, intravenous, not gonna be the most convenient. However, I'll pass it off to Justin and he's gonna talk about some medications that are luckily PO.
Yeah, thanks, Beth. So we're going to talk about the 2 oral agents here. So molnupiravir is going to be the first one. So just a little bit of background for everybody. So molnupiravir is a ribonucleoside that interacts with RNA polymerase and causes kind of disruption to the viral replication and results in these like deleterious errors. So really kind of interrupts that replication. It has a lot of activity, so pretty broad antiviral activity here. So one kind of hopeful thing with its discovery is maybe we can use these for other viruses like RSV and other viral pathogens that we commonly encounter. The dose here is listed for you. So it's going to be 800 milligrams by mouth twice a day for 5 days. Again, within that 5 days of symptom onset when those patients are kind of ramping up the viral replication. Of note, just for, since we're all pharmacists on the line, 200 milligrams times 4, it is a 200 milligram tablet. So quite a big pill burden, but at least a fairly short duration here. So molnupiravir was studied in the MOVE-OUT trial, which is a phase 3 double-blind randomized placebo-controlled trial among non-hospitalized unvaccinated patients. These were all determined to be high risk by investigators. So they included at least one risk factor. So you can see 99% of patients included had at least one risk factor. However, when you actually go into kind of the details here, very similar to our trial with Paxlovid. It's not frequently patients with multiple risk factors. So even one being obesity, which you can see is the predominant one, can include patients in the trial. Again, within 5 days of symptom onset. During the study period, Delta was the primary variant. So most of the patients did have Delta. And most patients were also located in Latin American countries. It was about 1,400 patients across 20 countries, so pretty good representation. And the primary endpoint here was any hospitalization or death at day 29. Of note, so this image here is actually Thor's hammer. So when molnupiravir was first introduced, there was an interim analysis that showed really great results, upwards of like 80 to 90% relative risk reduction. And then we saw that kind of drop off in the full analysis. And so here you can see kind of the full analysis going on. The one thing that I wanted to point out was those patients who had a negative nucleocapsid antibody. So those patients who previously had a SARS-CoV-2 infection, that's where we see kind of a drop off. So those patients who had never had a COVID infection previously, again, these were unvaccinated patients, but didn't have a COVID infection in the past, did show kind of more significant absolute risk reduction compared to those patients who likely had been previously exposed. And that's how we would determine it with that nucleocapsid difference. Also here you can see the baseline SARS-CoV-2 antibody assays and not a huge difference between those that had detectable antibodies versus undetectable antibodies. So again, based on the full analysis here, molnupiravir kind of lost its luster. And as a result, it's recommended as kind of a last line treatment option for those patients who don't have access to sotrovimab or Paxlovid. And then speaking of Paxlovid, so this is nirmatrelvir ritonavir. It's a SARS-CoV-2 main protease or MPRO inhibitor plus that HIV protease inhibitor. So what nirmatrelvir does is inhibits that MPRO from processing polyprotein precursors and again disrupts that replication phase. Ritonavir of note, I'm sure a lot of people on the call are familiar. Doesn't have activity against SARS-CoV-2. It was initially studied as a potential agent, but didn't really shake out with any efficacy success. But it's a CYP3 inhibitor and it increases the concentration of nirmatrelvir, so that's why it's co-formulated that way. The dose here is 300 milligrams oral, so that's 2 150 milligram tabs of the nirmatrelvir plus 100 milligrams of the ritonavir. That would be taken twice a day for 5 days. And there are renal adjustments located here for those patients with eGFRs 30 to 59, and then it's not recommended if your eGFR is less than 30 or it's an ESRD patient. The big thing to kind of call out with Paxlovid is really the drug-drug interactions that we'll see. So we'll go through that in a few slides, but makes it a huge challenge for prescribers and pharmacists to kind of manage this, when to adjust versus when to avoid Paxlovid altogether. The data here was really driven by EPIC-HR, which was a phase 2/3 double-blind randomized placebo-controlled trial, again, among non-hospitalized unvaccinated patients with mild to moderate disease. So during that kind of initial viral replication, again, the primary variant was Delta here, and these patients were enrolled within 5 days of symptom onset. The longest duration was about 7 to 9 days, but the median time was around 3 days for both the Paxlovid and placebo group. So pretty good inclusion of just those early patients. Here we had about 2,000 patients among 343 sites, and the primary endpoint was similar. So COVID-19 hospitalization or any death at day 28. I did just want to call out the serology status here. So again, if a patient was presenting with antibodies, you can see it's very similar, the majority, well, kind of split down the middle, but negative and positive in terms of their initial presentation if they were mounting kind of an initial immune response. This is just a further breakdown of the Paxlovid and EPIC-HR trial. So it's a little small, I apologize, but you can see kind of in table A, so this is from the supplemental material, there's really no difference between, or not a significant difference between those patients that were included within 3 days of symptom onset versus within 5 days. And so that's where that recommendation comes for the agent to be used within 5 days of symptom onset. You see maybe a slight kind of risk reduction or percentage of the primary event. So about 72% or 0.72%, excuse me, versus 0.77% when you're looking at 3 versus 5 days. In table B on the left, this is the viral load response. So you see those patients with higher viral loads had a more significant relative risk reduction. And that's something that we would assume being an antiviral. And then in table C, I just wanted to call out again, kind of no major difference between those patients who are included within 3 days versus greater than 3 days of symptom onset. And you see that maintain relative risk reduction, maybe just with a wider confidence interval for those patients who are further out from initial onset of symptoms. And then they also, again, included kind of the breakdown for that baseline serology status. And this is where it does become important. So again, we said it was about 50-50 split, but you see those patients who weren't mounting a response had a significant improvement with Paxlovid compared to those patients who were already mounting kind of a response. Really, it's a lot closer to that non-statistically significant difference compared to placebo. So this is just something I think, especially if you have patients who are not able to mount a response, i.e. those immunocompromised, high-risk patients, especially with like B-cell depletion, this would be something to recommend in those patients if there aren't any additional contraindications. I did just want to call out, so the EPIC SR or standard risk hasn't been published yet, but there are initial kind of preprint press releases about it, and there was really not a significant change compared to placebo. And that's probably why we haven't seen the data yet. So I don't know if they're going to be recruiting more people or if we'll be seeing that published soon. But again, we want to focus the use of these drugs in our high-risk populations. So speaking of drug-drug interactions with, again, that ritonavir component, so most groups, including the NIH and IDSA, have bucketed them into 2 groups. So those maintenance meds that are kind of chronic medications that are unable to be held. So you can see some of them bolded here: amiodarone, cyclosporin, rivaroxaban, tacrolimus, et cetera. Those agents typically are something that are not going to be able to be kind of changed out or held by the patient. So Paxlovid would not be recommended in those patients, again, due to kind of the drug interaction with ritonavir. The second grouping here is really those patients who are taking medications that are modifiable. So we can either switch it out or have them hold. Alprazolam, et cetera, you could probably switch it to something or have the patient hold. If they're using tadalafil for erectile dysfunction, you could have them hold. Statins hold as well. Most guidance is for the patients to hold the medication for 2 to 3 days following the completion of Paxlovid, depending on the half-life of the co-medication. When in doubt, just want to plug for all of us here, ask your pharmacist. So I know a lot of our prescribers have really leaned on inpatient and outpatient pharmacists to help determine which patients are appropriate. Here at NMH, we actually took the approach, especially for our solid organ transplant population who are on some of these 3A4 substrates, tacrolimus, sirolimus, cyclosporin, everolimus, et cetera. We are avoiding use in those patients, so we would prefer sotrovimab, again, due to similar efficacy and avoiding these drug interactions. But really, I think this has been a nice space for us pharmacists to step up and take an active role in determining appropriate therapy for patients. A few other resources here for you. So drug-drug interactions, there is a lovely checker from University of Liverpool that's really robust and gives you good kind of guidance in terms of how to manage these interactions. So you can type in the drug, Paxlovid, molnupiravir, they're both there. And then any co-medication, I will say watch out for some of the spelling sometimes because they're like British English instead of American. But otherwise, it gives you really good guidance of which drugs to avoid. So when in doubt, I think plug all of the patient's medications into this list just as a double check. And the website is listed here for you. In terms of access, so we said these are hard to get your hands on. That was the case probably in late January when they were first rolled out. It's becoming a bit easier to find these medications. That's largely driven by kind of a lack of demand. And I think one kind of criticism is these drugs weren't rolled out, or access to these drugs weren't rolled out, early enough. So we saw that Omicron peak kind of right after Christmas, early January, and then access to these drugs kind of fell after that when things were already tapering off. However, who knows when the next surge will happen, if it does happen. So I think knowing how to get your patient access to these medications is a good thing. So ASPR and HHS have a lovely resource that's across the country. It's a map that you can zoom in on and find location by location what the actual availability is, and that they'll give you the quantity that's available. IDPH also has a local version of that for the state of Illinois. It's more qualitative, so they'll just say yes, no, we have the agent that you're looking for. They're currently only available at Walmart and Walgreens locations, although there are talks for maybe that to expand a little bit, depending on kind of the federal government's approach. Walmart does not allow you to call the pharmacies. So we did receive kind of a notification that they prefer people to use this online checker. Walgreens still allows you to call and ask. And I think that's best practice. So we actually implemented some Epic kind of order logic to shunt prescribers towards these available pharmacies to prevent kind of lack of access. Just in terms of therapy overview, so I won't go over this too much, but big things to kind of keep your eye on for sotrovimab, nothing really other than infusion-related reactions. Again, it's that one infusion over 15 minutes, and maybe we'll get an IM version down the line. For Paxlovid, the big things are going to be renal and hepatic dysfunction, so dose adjustments or avoiding therapy there. And then the major consideration is obviously drug-drug interactions, so making sure that the patient's not taking anything that would decrease the Paxlovid concentrations or potentially increase the levels of co-medications. And then those patients who are pregnant or trying to become pregnant should use non-hormonal contraception. That's also the same for molnupiravir due to risk for embryo and fetal toxicity. And there's more specific guidance here. So avoiding use in pregnancy, female patients who are childbearing or trying to become pregnant should use contraception during treatment and for 4 days after the last dose. And then male patients should do the same and then continue for 3 months after the last dose. Also of note for any of the peds folks on the call, molnupiravir due to some bone and cartilage toxicity should be avoided in those patients less than 18 years of age. They are still EUA authorized, so any adverse event should be reported, and the link for the FDA MedWatch is here. This is just a summary for, takeaway. Again, you can see the relative risk reduction. So about 80% for sotrovimab, upwards of 90% for Paxlovid, and then that major drop off to 30% for molnupiravir. And that's why we see kind of our lower recommendation for that agent. So Beth, if you want to take us through how to prioritize these agents.
Yep. So talking about these 3 agents, we're kind of thinking, where do we rank them? The winner overall, shouldn't say winner, but the first line is going to be Paxlovid, and Justin has already told you about things to watch out for, but Paxlovid is going to be our #1 agent. If Paxlovid is out, in order of importance, we've listed here, sotrovimab is going to be second. Again, you're worried about, okay, how do we set this up logistically? How do we get an IV infusion? Luckily, it's just a one-time dose. Third on the list, we did put remdesivir in here, and remdesivir seems to be the jack of all trades. Use it inpatient, use it outpatient. We didn't have time to go over that here, but remdesivir is actually an option in the outpatient setting. That's a multi-day drug regimen, though, that's given IV, so logistics could be tough there. Unfortunately, molnupiravir falls to almost dead last, just because the data for the other drugs is so much better, but it can be used in the case where you can't get access or you can't use some of these other agents. You've probably heard, yes, it is a word, bebtelovimab. It's a new monoclonal antibody. The data is just not there yet. So currently the CDC is saying, okay, you're going to use bebtelovimab at about the same pace that you're going to use molnupiravir. Try not to do it. Not because it's not great, but just because we don't have the data yet. So stay tuned. You might have another MAB to learn how to pronounce. So with that, let's go over our first case here. And I know we're cutting it close on time. If you guys do have questions, please feel free to enter them in the chat. But we've got a 60-year-old patient here who has been diagnosed with COVID. And you see some of their medications here that are bolded. Maybe you can remember what Justin had said about drugs to avoid. And if we go to the next slide, I think that is our official poll. So you've got a 60-year-old, He's got some medications that maybe spark a drug interaction. So we've narrowed it down to the 3 options that we've discussed today.
Our audience is on it clearly. So sotrovimab all the
Yes.
way. And we
Yes,
agree.
Justin, you did such a great job. So to bring the question back again, we've got our little conclusion box that will pop up here, I believe. Yep, that tells why sotrovimab is the best answer here. Again, we're just trying to avoid those drug interactions. Spoiler of what's to come, I'm going to pass it back to Justin for the last 2 cases.
Yeah, so we'll run through these quickly, but similar patient here, unvaccinated, PCR positive this morning. They're on atorvastatin and sildenafil PRN, nothing else that interacts. So again, think about the buckets here. Which one would be a maintenance med that we can't change out versus something that we could potentially hold in a high-risk patient? And so same options, Paxlovid, sotrovimab, molnupiravir, or supportive care only. All right. I agree. So Paxlovid would be an option for this patient. Again, with the medications that the patient's taking, atorvastatin, that's something that should be easily held. And then sildenafil as well, we can have them avoid that. So Paxlovid would be preferred here due to those relative contraindicated co-medications. The patient's tier 1, unvaccinated, has a bunch of risk factors. And I think we threw in there that is a fear of needle stick. Really, you could consider either one, sotrovimab or Paxlovid. But logistically, Paxlovid may be a little bit easier, especially if we're able to hold some of these meds that would cause drug-drug interactions. And then lastly, we've got a 46-year-old. It's a little different. They've got myalgia and rhinorrhea. Their past medical history, which is important to note, is ESRD, as well as AFib. They are vaccinated, no booster, tested positive this morning. They're on atorvastatin and warfarin. The patient's not admitted and they can't have access or don't have access to sotrovimab. So what would you use for this patient? Again, ESRD, so think about the contraindications related to some of our oral options, and sotrovimab is not available for this patient. All right. So we got 50-50 molnupiravir versus supportive care. And again, I think that's reasonable based on the patient's risk for progression to severe disease. Granted here, there not a lot of past medical history. ESRD and obesity as well as AFib would put them into a high-risk category. However, you could base it kind of on their overall response. Is it just this mild kind of rhinorrhea, et cetera, or are they at higher risk for progression? Here, probably the data would support molnupiravir, again, for about that 30% relative risk reduction. We would avoid Paxlovid due to those absolute contraindications with his co-medications, i.e. warfarin here. And then sotrovimab, like we said, wasn't available in his area. So with that, that leads us to the end. Thank you for sticking with us. We'll take any questions that you have, but thanks for joining.
All right, we have one question. What was information regarding warfarin for the last question?
Yeah, so in the last one, warfarin would be contraindicated, the statin as well, potentially, if they weren't able to hold it. Obviously, it's not the major substrate there, but just some concern. And I think at one point, especially if the patient were on a different anticoagulant, so if they were on rivaroxaban or apixaban, that would be even more of a concern. So that was the reason why Paxlovid was avoided in this patient.
Thank you both again so very much. Bye-bye.
Thank you very much.
Thanks, everybody. Take care.